So my name is Mena Hyder. I'm a medical oncologist in the neuroendocrine program here at Moffitt Cancer Center. And I'm very thankful for you giving us your time today. And I want to thank FLaNET for helping us put together this webinar series. Today, we're going to be discussing nutrition in neuroendocrine oncology. And when I think about nutrition, specifically in that it's really multifaceted. And of course, we have limited time today, so we are going to focus on the changes in nutrition that can happen after surgery for a neuroendocrine tumor. But we hope that in the future, we can cover more topics that encompass, other facets of nutrition that we deal with together in clinic. And I'm pleased to be joined by our two speakers today, starting with Mr. Carlos Goffi, who is a patient and is kind to share his time and his story with us. He is a former professional tennis player and coach. As a teenager, he represented his native Brazil in international tennis tournaments, and in 1970, he became a pioneer student athlete from Brazil to attend college in the US, where he received degrees in psychology and business administration from the University of Kansas. He continued on as a professional tennis coach and author, and he coached John McEnroe and his brother Patrick as juniors and as professional players. He wrote a book with John McEnroe titled Tournament Tough, which is a bestseller in 1984, when he was the best player in the world. So he had a lot to share in that aspect as well. Mr. Goffi's son, Josh, is also an avid tennis athlete, and he's the men's tennis coach for the University of South Carolina with a great record this past season that you shared with me, and he's got the shirt to support on as well. Carlos currently lives in Central Florida, where he's an active in tennis and real estate, and we also shared his website if you're interested in learning about those efforts. I'm also joined by my colleague, Tiffany Valone, a physician assistant in the Department of Gastrointestinal Oncology, who I have known for years. Even when I was in training, she was teaching me back then. She started her career at Moffitt in the GI Oncology Department in 2006, and has since excelled to be the supervisor of our advanced practice professionals in 2014, and was awarded the Advanced Practice Professional of the Year in 2015. She's a Florida native. She attended University of Florida, like myself, and she's board certified by the National Commission on Certification of Physician Assistants and is licensed by the State of Florida Board of Medicine. She is a co-investigator on multiple clinical trials and plays an active role in the training and mentoring of new advanced practice professionals within our department, where she continues to be a leader. And she is a wonderful part of the team, and I'm so happy to have both of you join us today. So I want to take a moment and allow you to introduce yourself as well. Tiffany, I'll hand off to you if you can share your clinical experience and what your goals of discussion today are.
Sure. Thank you, Mena, and welcome, Carlos, and welcome to everyone that is able to participate in today's webinar. As Mena said, I am a physician assistant here at Moffitt. I work with the neuroendocrine team. I've been working alongside Dr. Strasberg for the past 15 years. So I always have to give thanks to him for all of his mentoring. I wouldn't be able to be here and share all of my knowledge if it wasn't for all his guidance over the years. But I have the pleasure of treating our NET patients and nutrition and managing patients' nutrition throughout their cancer journey is one of the entities that's near and dear to my heart with treating this patient population. And so hopefully by the end of the conversation today, we'll share some information about in the post-surgical period of ways to improve nutrition and kind of what questions you can be asking your doctors. And we'll talk about some different classes of medications that might be used or tried to help improve overall nutrition.
Thank you so much. And Carlos, if I can hand off to you, I think your audio is working well. Can you share a little bit more about yourself and if you're comfortable giving us a brief history about your diagnosis and the treatment as well?
It's a pleasure. It's my pleasure to be here with you all. Thank you very much for inviting me. And I believe that those that are participating will get information that it's all needed for us that are going through what we're going through. Before I go on, apologies for the mess that my office is in. It just got painted a couple of days ago and pictures are still on the floor, so don't look too far back. My situation was very unique because it happened 4 or 5 years ago, right through the holidays. I was not feeling very well, and I was not very hungry and feeling a little stressed. And my wife was saying, "You've got to go to the doctor," you know. And I was not. I haven't been a real going to the doctor for anything, you know. I've always sort of took care of myself as well as I could. Being in the athletic field, you kind of learn this since you are a teenager, that you've got to take care of yourself, take care of your body, and so forth and so on. And you just don't go to the doctor because you just got a cold. You just tough it out, as we talk about it. And but she insisted, and right after the holidays, I ended up going to a gastro doctor here in Winter Park. The first question, as he was making notes and so forth, was let's have a colonoscopy. You haven't had a colonoscopy for a few years. At your age, you know, you should have done it about, you're overdue for about 5 years. Okay. And this is a very interesting point because there are many places, I guess, that you can have colonoscopies. And this fellow, because we had this relationship at the country club here in Winter Park, beyond the professional relationship, he told me when I woke up that I had no issues with the colonoscopy. Everything was fine, but he saw a marker that made him go one step farther. And that what he suggested at that point is for me to get a scan. And he scared me right off the bat. And he says, "Look, let's just don't get scared right now, but let's just get you to get a scan." And of course, as soon as I was able to get that scan, he said, "From now on, I've got to send you to an oncologist. You do have a mass in your intestines, and that needs to be taken care of immediately." Well, that was the shock of the century, as I'm sure anybody that is here that gone through what I went through can relate to my situation. And so I went to an oncologist here in Altamont Springs, and immediately through my research, I found out that Moffitt was the place to go. And that's how I got to Moffitt. And I could not be happier with the care that I've had. The surgery was a success. It was a long surgery. It was about a 6.5 hour surgery, my primary surgery. Dr. Fleming was phenomenal, and his staff or his associates. And as it turned out, they were able to do an intestinal recession. I believe that they took about 6 feet off my small intestines and a couple of other things as well in the process. And all of a sudden, my life changed completely. And here we are. I think we are 4 years into it. Dr. Hayter has been nothing but a fantastic sort of a, you know, guiding angel for me. And there's a lot of adaptation that needs to be done. So without going into too much of detail, that's what happened pre-surgery, during surgery, and immediately post-surgery. Since then, I've been learning a lot. Dr. Hayter has been teaching me a lot. Of course, I go through those scanxieties, as we call it, right? Every so often, it's one of the worst things that can happen to me. I mean, I've played at Wimbledon, and that was like a piece of cake compared to like going out and having these scans and then having to go and face Dr. Hayter, because I don't know what's going to come out of her mouth when I am I'm seeing her right after the scans. Knock on wood, so far things have been going well. She has graduated me from the every 3 month scans. Now I'm on the 6 months scans, and I am on the treatment that every single month I take that lanreotide shot at the hospital. It's manageable, and I will conclude my introduction with this. When my tennis fans say, so wow, what's the prognosis? What's going to happen with you? Because I did lose a lot of weight, by the way. I used to be a 225-pound big man, and I'm down to about 170 pounds right now. So anybody that has known me pre-condition and now realize that something has gone on with my body. Some say, well, what is your diet? I'd love to have that kind of diet. I said, well, I don't think you want my kind of diet. But with that said, in my tennis terms, I won't let this condition beat me. In tennis terms, I keep telling everybody, even if I can beat it, if I continue to hold my serve, the match will never end. So I'll leave you with that.
Thank you. I love the terms that you used, and thank you so much for sharing your experience. Before moving on, there should be a way for you to raise your hand on the screen, or you can press it. And I just wanted to know, if you're comfortable, how many of those who have joined us today have had surgery for neuroendocrine tumor, just to put things into perspective. And if it's many of us who have had surgery, or so I see Dr. Faith has a hand raised.
Alan has his hand raised too, and so does Virginia.
Yes.
Oh, okay. All right. So this is quite applicable, and when we get to the discussion, we can hear your experiences as well. So Carlos, one thing I learned about you, and I think it's because you're an athlete and you train future athletes, you were very in tune with your nutrition and your body. And so can you share a little bit about, when you were first diagnosed and you were already having symptoms of gut changes, if you will, you were looking at your nutrition before surgery. Can you share a little bit about what worked, what didn't work, how that biofeedback was for you?
Yes, well, as I said in the beginning, it took me about 3 months of not really being that hungry and not feeling very well, a little queasy, a little, so I didn't realize what was happening. I attributed it to stress towards the end of the year, stress, all kinds of things were happening in my life at that point. And I thought, once the holidays are over, I'll be fine. I'll be back. And it didn't get any better. So to answer directly your question, while I wasn't diagnosed, but I was beginning to suffer the symptoms, I was really just not feeling myself, but I was not hungry. So my diet was very, very light at that point. And that's what started to raise concerns with my wife and, and my family, and particularly during the holidays when they all came here, and I was not really eating that much. I was not really being myself that much. And so that's what went on during that period. Following surgery, I was able to leave Moffitt with a series of guidelines and instructions and so forth. And I began this road that I've been through ever since. But what I did find, which is the obvious that you even told me, Dr. Hader, and a couple other people, is that caffeine, for instance, anything that actually promotes, going to the bathroom needs to be, exited from your body. So what is that you can take in and that you can keep it in, so your body can absorb the nutrition and feed your muscles again. People look at me and say, "But can't you just work out and all that?" Look, I am being as physical as I can possibly be still, but it's not a matter of putting weight on when you have this condition. It's very interesting because it's not about exercising, it's about feeding the muscles, obviously. So the muscles can exercise, but if you cannot feed enough that muscle is not going to grow. So not only I lost all the fat in my body, but I lost a lot of muscle as well in the process. I'm happy to say that I've been stabled. I'm being able to stabilize between the 165 and 172 pounds right now. It is not rapidly just losing it anymore. I am taking protein shakes. I do the plant-based protein shakes. I look for protein shakes that do not have very much fiber, because fiber, again, is a problem for people in my condition. So anything with fiber, I've done away with it. And then, of course, I have to supplement that with multivitamins. So I take a lot of multivitamins. I'm not eating broccoli anymore. I'm not eating beans anymore. So if I'm not getting the nutrition from broccoli, from beans, and everything else that I was getting before, I've got to supplement that with non-fibrous protein. So I found that you can buy protein powders and make shakes for proteins that are less taxing on your digestive tract, particularly those that don't have fiber in it. The other thing that I have found as well is that movement is what causes immediately the gastro system to put you in the bathroom. So I found that during right after breakfast, I have to try to really calm down and settle down. I can't just have breakfast and walk out to a meeting anymore like I used to, because I cannot afford to be caught in an emergency. Same thing with lunch. Lunch times are always a difficult time for me, because if I have a meeting after lunch, I won't eat lunch. I will go to the meeting without it. When I travel internationally, I don't eat for a day before I travel internationally, because if I'm staying in the airplane for 9 hours, and through passport control lines and lines getting into an airplane, the last thing I want is to have that stress of having to find a bathroom. So it does change my life. You have changed my life completely, because I've got to time every time and everything that I put in my system. But in closing, caffeine, fatty stuff, spices, smoked meats are horrible for me as well. And of course, eating too much. So that all of that contributes to the symptoms.
Thank you, and thank you for highlighting how much this does affect a lifestyle change. And I think it's something that we all, can need a moment to recognize. Yeah. And I think that you shared some things that work for you. It may be completely opposite for another patient, but there are some general concepts, Tiffany, that I think we, spend time reviewing. So can you share, when you meet with patients, what you prepare them for prior to surgery, and then what you look for immediately after surgery to prepare them when they're home? And then, we'll talk about that setting, and then we'll talk about months after surgery, what to expect.
Yes, certainly. And so I'll start with, like pre-surgery. And this really, I think, will span any type of GI surgery. I know that we're, really trying to probably focus today on bowel surgery, but it would work the same for any surgeries on the pancreas as well. When we're prepping patients for surgery, absolutely having them in the best shape possible is key, and what we are striving for. What Carlos described is, definitely what we see a lot in the majority of the time, and that is weight loss, patients coming to us, difficulty eating, trouble with digestion. And so that can be, troublesome and also difficult to get the patient, properly prepped for surgery. But some of the things that definitely across the board will work is, most of us are used to eating 3 main meals a day and then maybe snacking. Well, we know that, trying to eat just grazing, or what I tell patients, maybe no more than the palm of your hand, but that portion size, but trying to do something and put something into your body, high protein, good fats every 90 minutes to 2 hours. And that way it's not too hard on your body to try to digest that, is better than eating 3 main meals a day. If patients are having trouble eating solid foods, then definitely we recommend adding the supplemental drinks, or with even just that grazing, if they're not getting enough calories, throughout the day, supplementing with new nutritional drinks. And so, there's a variety of them on the market. And at Moffitt, you can go to our pharmacy and you don't need a prescription anymore. You can ask for their menu of nutritional drinks, and they're anywhere from dairy-based to a non-berry juice called Breeze, all different flavors. And so, usually at this time, we are also requesting that the patient meet with one of our dietitians and have a consult, so that they can, we understand as providers, going over the surgery and going over the diagnosis and then talking about nutrition, a lot of it is lost. And so we need to do that re-education with the patient, getting them prepped for surgery. And our dietitians have been phenomenal in that aspect of kind of driving home some of these points. So I think, the eating is one key. The second part is, I know it is challenging for our patients because they're not feeling the best, but still, like Carlos said, trying to maintain even a walking program or something to use your muscles and keep the muscles as strong as possible, because undoubtedly after surgery, no matter what type of surgery you have, you're going to experience initial weight loss. You're going to have initial muscle wasting and atrophy from lying in bed and trying to recuperate from surgery. So it's key to kind of go in as strong as possible. So that's kind of pre-surgery. Immediately post-surgery, and this is where it kind of differs depending upon the type of GI surgery you had, but specifically looking at small bowel resections and a right hemicolectomy, which is probably the most common GI surgery done for our small bowel carcinoid tumors. Immediately post-operative, when they're still in the hospital, they're essentially on a liquid diet, and that is gradually advanced. The surgical team does prep them that there is usually no fiber in the diet for the first 2 weeks. And then after 2 weeks, they can reintroduce a low fiber diet. And the low fiber, what they kind of quantify is around 2 grams of fiber per meal, probably not to exceed 10 to 12 grams of fiber a day. And that usually goes on, that recommendation, until the first post-operative visit that they see the surgical team. And at that time, if the patient is doing well, they can increase the diet to, normal dietary fiber, which they say is up to 30 grams a day. But like Carlos said, it is definitely, each patient is extremely unique. And, the other challenges, so each of these patients, when we're seeing them and kind of giving our recommendations, that would be the recommendation if we got all of the cancer out and that the patient is not on any further treatments with somatostatin analogs like Carlos says with lanreotide, or if the patient has tumors scattered in their belly cavity, which we call carcinomatosis, those patients, again, will continue to recommend no fiber to low fiber, because again, they're having tumors that are disrupting the digestion. And so, added fiber will actually may cause more distress. So I'll pause there.
Thank you. Yes. I think, it's not part of our discussion today, but we use medications that also change how we digest and how efficient our pancreas is in the digestive process. So some treatments that we use also contribute to symptoms that disrupt digestion. I want to take a moment, Carlos, you talked about vitamins, and we have to be transparent that we're not as well versed about which vitamins should be absolutely reintroduced. But I think that your approach of looking at what foods am I not able to add back in and what components does that might leave me deficient in, and supplementing is so personalized to your body. And I think that's a really wonderful approach. I think we can do better in the clinic in recognizing that and going through food logs and working with our nutrition team. So you actually provided me some feedback there for me to implement. So thank you.
Thank you.
Tiffany, when I think about surgery, I meet patients after surgery, we heal really well externally, and quickly. But can you speak a little bit about timeline of how digestion heals right after surgery? Are we in the same place 3 months after surgery as we anticipate to be 6 or 9 months or even a year?
Right. So yeah, great question. So we have to remember, during surgery and after surgery, the surgeons are using antibiotics. So we're clearing out our gut of all the healthy bacteria as well. And we know when that happens, that can result in more diarrhea. So I think in the immediate post-surgical period, or if there's any period of time where patients are completing antibiotics, that it is important that patients take a probiotic. And that can restore the healthy bacteria. You can even get that from a simple yogurts at any of the grocery stores, or there is a couple different either pills or powders that you can mix into liquids. And so that should be kind of like a standard regimen post-surgical. But immediately afterwards, it's not uncommon, for patients to have a lot of diarrhea, especially with a right hemicolectomy and also our pancreatic surgeries. So, one of the classes of drugs when patients have, a small bowel and a colon surgery might be our bile acid sequestrants, like cholestyramine or cholestyramine. And those are used to bind the bile salts to hopefully bulk up the stool a little bit. Now, they might actually add to that doing, further along, I would say month, 6 weeks to the first 6 months, that using Metamucil or Benefiber may actually help as well, add more bulk to the stool. But I would say for patients, we tell them probably the immediate first 3 months is going to be drastically different than the month 3 to say 6 or 9. And then usually by a year, I tell patients that this is probably you've had a full year to recover, and what you're experiencing right now is probably going to be your baseline. And if there is ongoing diarrhea at that time, and in many individuals, there is, I think, it is quite challenging in the net population because, like you mentioned, some of the drugs that we give to treat the disease then can cause some malabsorption, maldigestion issues. And then we have to look at the patient's surgery, what surgery that they have that can result in diarrhea. And so then it might be, kind of playing a little bit of trial and error with prescribing different classes of drugs, including our antidiarrheals, Lomotil and Imodium, to try to slow things down, with the goal that, patients are able to enjoy a meal and not have to run to the bathroom, and so that they can, gradually increase their weight and increase their overall muscular, strength back.
Absolutely, yes. We want the surgery to serve you well, not just from tumor control, but lifestyle as well. Carlos, if we could take a moment, and then I really want to invite everyone for questions and sharing your experiences. If you reflect on time and you think about some of the, I think after surgery, we really worked on how are you healing, how is your digestion, and it's becoming more and more controlled. So immediately after surgery, would you say your symptoms were highest? And what symptoms have gone away, and what is your new, the symptoms that we're absolutely still working on? I think you hinted.
Go ahead, please.
I think you hinted about, the kinds of foods that work best, and then time to after eating to slow down as your long-term. But what has gotten better over time?
Yeah, well, what has gotten better over time is that I've been able to now manage better. I think that I've learned how to manage. So for instance, when I go and get my shot, my Laratide shot, I do know that 1 week after that shot, it is a difficult time for me. I've experienced that, constantly. It took me a while to figure it out what happens during those 3 weeks after that shot. But once, maybe after 6, 7 months taking that shot every single month, it became more of a pattern of how my body was reacting to that shot. And it is not fun. The first day I come back, I just feel normal. I guess he hasn't had time yet to cause the eruptions and the volcano eruptions inside of my body. And but within 24 hours to 48 hours, I go into a good 3-4 days of difficulties after that shot. So it takes me a week, and that has already talk about adjusting for lifestyle. So I have had, as you remember, Dr. Hader, to change the time of my shot several times, because all of a sudden I had to be in Los Angeles for something, and I said, I've already took that shot and flew over there, for something. And by the time I got there, I was miserable for the 4 days that I was doing something. So now if I have to get to do something or travel, I'll wait until I come back before I take that shot. So that's something that you learn, to adjust. And Moffitt has been super accommodating. I cannot say more about Moffitt. I tell everybody, I said, Moffitt is basically my heaven, because they take care of me when it's time for me to change the shot, because I have this commitment. No problem, everything gets changed. So it's been a very cooperative and a very wonderful place that I can feel comfortable and confident that I've been taking care of the best possible care I can possibly have with my condition. But the other thing we were talking about as well, with Tiffany talked about, diarrhea. I've always drank a lot of water, obviously, because as an athlete, you always try to hydrate and electrolytes and so forth. With this condition, when you have diarrhea, constant diarrhea, if you don't drink water, you can get lightheaded really fast, and you can get really dizzy real fast. So I understand. I kind of realized at first that I was getting a little dizzy and a little lightheaded, not because I was hungry, it's because I was dehydrated, obviously. And so that's the other thing. Now, I have tried, and I don't know, but I've never talked to Dr. Hader about that, but I have tried to eliminate sugar completely off my diet. I never really was a sugar guy that ate a lot of sugar, always knew that sugar was not good for you. But for all the research that I've done, I guess all forms of cancer, like sugar, and I certainly do not want to feed mine. So if I have a Gatorade, is sugar-free. If I get everything is sugar-free. My proteins are sugar-free. I just will not put sugar into my body as much as I can possibly do that. So I guess water, no sugar, smoked meats, and those are the kind of things that are very difficult. And I think that I can close by saying that the other thing that you learn how to adapt is that, or I would recommend to my fellow colleagues that are suffering the same situation that I am, is that make sure that you buy a nice comfortable toilet seat and a nice bidet. That's what I would recommend.
Thank you. I think that, the way I look at sugar is that we have to look at ourselves, and we look at our patients as a whole person. And we know that sugar can, processed sugar can predispose us to diabetes and obesity. And if we're not overall healthy, it makes our work together in controlling the net more difficult or more limited if we, have to take out resources of treatment because they work against you in that setting. So I think that those are good habits to keep overall for your overall health as well. There is a book that we'll be sharing that is available free, written by a nutritionist on the website, and you can request it to be mailed to your home. And she has recipes. She exclusively worked with neuroendocrine tumor patients. And so I think that is a great resource. Tiffany, are there any additional resources that are your go-tos? Because a lot of this work is done by our patients at home. This is things that are under their control, but we guide. But a lot of it is done on their own at home. So are there any resources that you think highly of that we should keep in mind?
Yeah, so one thing I do want to add about the sugars too, to keep in mind is when we do have part of our bowel, any part of our bowel taken out, eating sugar can actually increase the diarrhea. And so definitely, Carlos, you hit it on the head, and I didn't talk about that before. Like, hydration is key because of the amount of output with the diarrhea. And so we'll often recommend, electrolyte drinks, but do make sure that you do get the sugar-free type, because the sugar in, the electrolyte drinks that we recommend, or sometimes even in the protein drinks, can actually increase the diarrhea. So we're, doing a disservice in that. With regards to the resources, I mean, I am a huge proponent when patients, come to us to, and sometimes it's not just one, but 2 or even 3 follow-up visits with our GI dietitians and nutritionists. I mean, I think that they can offer a wealth of knowledge, and it is individualized for the patient, again, what they're actually going through and what their, at that time presenting symptoms are. And I would just strongly also recommend for patients to keep that open dialogue with whatever provider you are seeing. And maybe that's not even at Moffitt all of the time, it's your local oncologist in the community. But if you're not feeling right, back to what you feel is your baseline, or your baseline could be improved, and you're still going to the bathroom 6 times a day, and things are not right for you, to keep that dialogue going so that the team is aware and can continue to try to help you, ameliorate those symptoms, so that your quality of life is, can be improved. But so, I mean, I can't honestly think of any other like additional resources outside, or like websites that I direct my patients to. It's just, I want them to continuously have that open dialogue at our appointments, so that, if things are not right, we've had to sometimes circle back with GI. Like, if I feel like I've done everything in my spectrum of what I feel like I can do for their diarrhea, then I might, get our GI physicians back in the loop. Maybe the patient needs to be scoped again. Maybe we're missing some bacteria in the GI tract that, we're not treating with the meds that we would commonly use for neuroendocrine tumors. So, having that kind of multi-D perspective is something that we would do alongside with consulting nutritionist.
Excellent. Thank you so much. I want to thank you both. Carlos, thank you so much for being so open and sharing your experience, and Tiffany for your expertise. And I, wanted to dedicate a good amount of time for our community to share together. So we can start with any questions that anyone might have. You can press unmute. It's a, open environment, and or you can raise your hand, and we'll make sure that we can see you and open the discussion. Mr. Allen?
I had to figure out how to unmute there.
Yes.
Am I unmuted now?
Yes, we can hear you. Thank you.
You know what? I don't think I've ever met you, Dr. Hayter. And I was talking to somebody today, and they told me that you worked with Dr. Strasberg. So maybe I saw you once. I'm not sure. And hi, Tiffany. I found for me, I go along with what Carlos said on a lot of things, but between pancreatic nets and GI nets, they're completely different from each other sometimes when it comes to the symptoms involved. I don't really necessarily have a question, but I found with me, I'm 2 weeks post 3rd alpha treatment on the trial. And I'm finding that as good as lanreotide is for us, and how long it kept me stable, almost 4 years, it's a problem as far as causing problems in the GI tract. Now that I'm not on it during the trial here, either I'm feeling better from the trial, or it's the lanreotide that was causing the issues, because I find myself feeling, for the most part, in a month's time, much better, tremendously much better. And usually peanuts don't have trouble with the diarrhea, but I don't necessarily agree with that, because I think we do. And there's a lot of us out there that do suffer, and maybe it's just the lanreotide that causes it, but the lanreotide is supposed to be helping it.
Yeah.
And as far as the sugars are concerned, I was told early on, I'm coming up on 7 years, and I was told early on by Dr. Strasberg, eat whatever you want. And I find that I do have some things that cause me problems, but I can't stop eating them because they're cultural. Like I'll have bagels, lox, and cream cheese, and that's smoked fish, and I love it. And it's one of my favorite things on the planet. So I deal with it, and I don't necessarily. The biggest thing I have is post-surgical, is from greasy foods. Anything greasy is a problem.
Yeah.
And sugar-wise, I'm diabetic anyways. So I wear a pump, and it pretty well controls my sugars for the most part. But the greasy foods is always a problem. Anytime I have anything greasy, I don't have problem with spicy. I don't have problems. I can eat salami, which is one of those meats you're not supposed to eat, a processed meat. So anyways, that's what I have to say. I think it's the lanreotide that has caused most of the issues. And I switched over to octreotide for a while, and I still had some issues. But now it's only like twice a month without the lanreotide, where I have like a day, and that's it, So anyways, that's all I have.
Thank you so much. I think you highlighted what we were, started our discussion, that everybody is different. Every neuroendocrine tumor truly is different. And I saw that, both of you were nodding that greasy foods are a problem for you, but you can tolerate some things that Carlos can't, and vice versa. And Tiffany, I think you can speak to somatostatin analogs and the symptoms they cause. I think that there's a role for a treatment change when it's needed, but it's always looking at overall risk versus benefit. But when I think about gastrointestinal symptoms on treatment, we should not overlook that you can have pancreas insufficiency, and that needs to be addressed, or different surgeries. So if you're missing part of the colon or small intestine, you're going to have a very different experience in transit time versus pancreas surgery, and then the issues in digestion with that. But thank you for highlighting.
Yeah, and I was about 13 hours on my surgery. It was a doozy.
I think there was a message, and we will resend the link with the website as well, Dr. Faith. Anyone else with questions or comments, something to share with the group? We still have 10 minutes together. I'd love to hear from anyone. Or I can keep talking, but.
Can you hear me?
Yes.
Hey, this is Virginia Robinson. The last time I was in Moffitt wasn't very long ago with the block valve, but they wrote me this thing for physical therapy. And it's like continuing. It's not like just 6 weeks. It's like forever. And I go to physical therapy 3 times a week. But I've been going on my own dime now for 5 years. But this has helped tremendously on that bill. And it's just helped wonderfully. It's just something that you need. And it is 101 exercise, and it's made me stronger. I found myself extremely weak, and I'm just toned up, and now Medicare's paying for it. I'm well over the Medicare age. I think it's a good thing. It's something to look into, and it's something Moffitt provided for me the last time I was in there with the blocked bowel. So something to think about. I truly think I started physical therapy or exercise with a private instructor about 6 or 7 years ago, and it has helped me tremendously. And probably because I'm too lazy to do it by myself at home, which is also possible, but I don't seem to be able to do that. But when I'm paying for it, I show up and I do it. I think that the whole physical thing has helped me a lot for everything. That's just something I wanted to bring up because it really, I felt so much better after I started the exercise. That's it. Also about the hydration, it is really important. You can get dehydrated very quickly for whatever reason. And I'm not talking about exercise. I'm just talking about during the day. If I don't drink a lot of water, I get it quickly. But I was just looking because I have Pedialyte and I have Liquid IV. One of them has 18 sugars and one of them has 11. I'm going to get on Amazon this over, try to find one with less sugar.
Yes.
I do watch my sugars and I do watch my fiber big time. There is a book that I go to constantly. Let me get the title of it. And it's about, and it has fiber counts in it. Where did I put it? Oh, here it is. Because I'm counting the fiber in peaches yesterday. It's called Food Counts by Corinne Netzer, Netzer. And it's a complete book of food counts, but it doesn't do sugar, but it does do fibers. Like I know that I could have a half a cup of peaches, I peel them, and it's only one fiber. So it's, I go to this book every time before I put anything new in my mouth, because I don't want to end up with blocked bowel again. But, oh, here's something. Oh, BioSteel, is that the hydration?
You're muted, Alan. You're muted.
Press it one more time, Mr. Allen.
I would like to.
There you go.
There you go.
There.
Yes, BioSteel, as far as ingredients, you got 1 gram of total carbs. And you
Wow.
got, I'm gonna say that, you got to look at when it comes to sugars, because I'm diabetic, I count my sugars, but I count my carbs more importantly, because there is a lot of hidden sugars in everything.
Yeah.
White rice is horrible.
Oh, I don't eat white rice.
And I love sushi, and there's a lot of different things out there that are hidden carbs. Pastas are really bad, and they're loaded with sugar. But this has 1 gram of total carbohydrates per. I think you can make a 16-ounce drink with this.
Right. Okay. I've written it down.
BioSteel, and they got a couple different flavors that are really good, and they don't taste chemically. So, and now the NHL is sponsoring BioSteel. So all of the hockey players use BioSteel, and it's only because it tastes good. Anyways,
Thank you.
I stand by it. And I fill my 40-ouncer up about 6 times a day, at least, at minimum. So I use one of the little tubes per 40 ounce, and I fill it with like about a third with ice and the rest with water.
Oh, that's good.
One little thing, and I drink. But I have to, because of the alpha, I have to drink a lot of water, trying to flush it out of me. So, anyways, I find it makes me feel better.
Thank you both very much for sharing. I'm going to find this book, and now I'm going to order BioSteel and check it out myself. So, and I think it's helpful for everyone.
This flavor is called Rainbow Twist, right here.
Mm-hmm.
And then I have another one. There's one I don't like. It's a blue one. I don't know the name of that one, but the white one is really good too. It's this one.
Okay.
And this flavor is called White Freeze.
Excellent. Thank you.
Uh-huh.
And you know, it's a great reminder that when we have our visits together in clinic to recognize that it's really a team approach in physical therapy, occupational therapy, nutrition, as you mentioned, Tiffany, our you know, neuroendocrine tumor care is really multifaceted, and we have all these services available. And just you know, in keeping the dialogue going is to remember to re-engage for that. We still have a few more minutes if anyone else has advice. Miss Ashley, and I think you can unmute yourself. Yep.
Hi, I'm Ashley. A quick synopsis of where I'm coming from. I have my primary was small bowel tumor, stage 4 neuroendocrine cancer, peritoneal carcinomatosis. I saw Dr. Strasberg, who identified I was in a high risk category and could not do Lutathera, and didn't recommend, you know, the alpha trial at the time. And he got me to see the one surgeon probably in the world who could even do the surgery that I required, because I had already been shot down for 1.5 years for surgeries from 12 different surgeons in 9 different states, or 8 different states and 9 different hospitals. But anyhow, so I'm about 3 months post-surgery, but I just wanted to share that before I actually got diagnosed in, I think, April of 2021, I had gone, you know, I've been years having symptoms and what have you. I also have carcinoid syndrome because I have functional tumors. And so I've dealt with a lot of the symptoms that the group has talked about today. But before my diagnosis and before realizing what we were dealing with, I switched to the keto diet. And that actually resolved a lot of my symptoms, not all of them, or it decreased the ones that it did not resolve. Up to the surgery, I had been keto for just under 4 years, and got a lot of benefit from that. Post-surgery, that's not possible because I can't really eat vegetables and all the things that we're talking about with insoluble fibers and what have you. But you know, I'm hopeful that I'll be able to get back to that, because I think that was where I saw the most benefit. So just something to consider. You know, keto is very difficult, but you can do modified keto, where it's just really like a low carb diet, and a high protein is often what I ended up doing, because my goal is more so to just listen to my body and feel better and reduce the inflammation and the sugars and the carbs and what have you. And it did make a big difference. And then I would also say, as far as because I was having a lot of malabsorption issues, I also was having a lot of lower extremity cramping pretty frequently, but I'm also very active and I also had to do a lot of research trying to find a good, you know, drink to help with the electrolytes and what have you. And I found one called LMNT, which I think is pronounced element, but it's just the letters LMNT. It's very salty, but it's a really good combination of sodium, magnesium, and potassium. And that was, I had been through like a dozen different electrolyte drinks over the years that I didn't really feel like were making a difference. But once I started drinking that one, I actually saw a significant reduction in the cramping from the malabsorption and what have you. So I also, you know, when we talked about some supplementation for vitamins and what have you earlier, I am prescribed a multivitamin and a vitamin D. We're monitoring calcium levels, but I also saw a neurologist because of all the cramping that was pretty severe. And, you know, we learned that we believe that it's likely the malabsorption caused a niacin deficiency, which makes it more difficult for the nerves to communicate to the muscles. And so I take a niacin supplement too. So it's a conversation I think that we don't have enough within the community, is not just the dietary approach. We do talk about that, not really in depth. We do talk about it, I think, also mostly in regards to, you know, carcinoid syndrome and diarrhea. But, you know, the malabsorption and the loss of nutrients that we experience with those symptoms that could cause other issues. or just fatigue or general, unwellness because you're not getting the nutrients that you need, I think is something that it would be great if we could, kind of monitor or test for more proactively. But that's been some of my experiences. So
I absolutely agree. I think that we could do better or more and kind of be more in depth. I think vitamin D is easy to look at and supplement. Niacin is infrequent, to find it, but when it's corrected, it's a big player. What do you think, Tiffany?
Yeah, I would agree. I mean, we know that, a great percentage of our patients, whether it be small bowel or organ or pancreatic, have malabsorption issues. And, with that, we have to definitely be cognizant of our fat soluble vitamins, that they may not be absorbing those. So our fat soluble vitamins are A, D, E, and K. And so that is something, again, that at Moffitt, unfortunate maybe that we don't routinely do it. We don't do vitamin levels. We usually refer out to primary care to have the vitamin levels drawn. But if patients do have a component of malabsorption, it would not be harmful for them to take an over-the-counter fat-soluble vitamin, which would include the A, D, E, and K.
If I could just dovetail on that comment, one of the challenges that I've found is that when I get referred back to my PCP, PCM, primary care to address something, even if it's vitamins, they oftentimes want me to go back to talk to my oncologist because they're kind of afraid to get involved in this complex situation that they don't understand because it's so rare.
Yeah.
I mean, I have a really hard time, even if I just get a cold, just going to primary care, urgent care to get my cold treated, right? So it's like my oncologist is now my primary care, which I'm sure is probably annoying, but it's more annoying for me to be bounced back and forth. But it's difficult is the point. But and then the other thing, what was it else that you said? I forgot the other one, but there was another thing that I wanted to share that in regards to what you just said. It might come to me, maybe not. Thanks.
Tiffany, what would be symptoms of malabsorption?
Symptoms of malabsorption can, there's a whole spectrum. So it can range anything from bloating and cramping after eating. It's usually after eating a high fat or high carbohydrate filled meal. Typically after that, there's fecal urgency, having to go to the bathroom, usually within an hour of eating. We call it like dumping. And the stool usually floats on the top of the water. It can have oil spots or look orange and have a lot of residue, be hard to flush, may have to flush a couple times. Usually very malodorous gas and frequent gas. And then, of course, we will see if that is malabsorption is going on for a period of time, that there is weight loss and we see a loss of BMI. And so that's something, the providers, we definitely monitor and track over the course of time.
And of course, then you can have very different symptoms depending on what is deficient. But Ashley, I want to go back to say, part of the reason I gain a lot from the webinars is that it sometimes puts a thought in my head and makes me better or more alert. And so I think today's discussion actually brought some things to my attention that can become more streamlined in clinic. So thank you. Okay. We have completed our hour together, but thank you so much, everyone, for your time and your questions and sharing ideas and things that have worked for you that might work for others. Our next webinar is going to be on July 27th, and we invite you and friends or caregivers to join us to talk about the role of a caregiver within the neuroendocrine community. It'll be a webinar just like this, and if you can't attend, they are recorded for your reference in the future. Again, Carlos, Tiffany, thank you so much for leading this and opening up this time together.
My pleasure.
Thank you.
Thank you all.
Thank you so much. Thanks, everybody.
Great seminar. Thank you.
Hope all feel better.
Yes.
Likewise.
Thank you. Thank you.
Good luck to everyone.